Hello and welcome to QOF Prevalence Training Session. This is being put on to help you and assist you with improving your QOF prevalence. My name is Luann Stewart and I am a practice manager of around 15 years in general practice, working at various different types of practices, and this will become relevant why that matters as we go through the training, because there are some different ways of dealing with prevalence depending on whether you work for an area with a very transient population or an area which has a more stable population. It can be dealt with quite differently. So we'll run through QOF prevalence with you today, and hopefully this will be useful. There will be some various handouts that will be available, and when you get your link for this video, it will be explained to you how that you can get those various handouts going through, and hopefully they'll be useful for you as well. These handouts are working documents. They have been made by myself, so they are not some glossy NHS England style handout. They would generally be a working handout made and used by a practice manager working in a busy practice, and I'll explain as I go through what handouts will come out to you and how they may be useful. So why are we doing this? Well, at all times, it's very complicated to get more and more finances to come into general practice, and this is one way of assisting the finances coming into general practice and increasing them without too much burden of work on the administrative and the clinical staff that would need to work through those areas. We will have a guide or a handout that will have very approximate amounts of money that can be increased within your QOF by increasing various areas of prevalence, and that will come out to you as will be explained when you get all of your handouts, and that will just show you which areas it's worth putting maybe a little bit more effort into to try and increase that prevalence, as they're all worth very different amounts of money. There are companies that will come in and do this work for you, and if you are in an area where you have a very stable population, this may be worthwhile. They do charge a percentage, some quite a high percentage, and some charge a set fee. They are obviously very good at what they do, but if you have a transient population that continues to move, it may be worth learning how to do this in-house, because obviously you could spend a lot of money getting this work done and then those patients move on. When you increase your prevalence, the finance will stay with that patient within your practice as long as that patient stays with you. So it is worth having a look at increasing prevalence and trying to keep those patients with you, so the money will follow you year in, year out, as long as those areas are still in QOF. Obviously, we don't know what's going to happen to QOF in the future. Doing the work in-house is not too arduous. Certain things do need a clinician's input, and I'll make it very clear as I go through the training session which areas those may be. To give you a little bit of background, this isn't something that you actually need to do, but it is useful for you to understand how prevalence works. Each surgery is under a contractor population index. This means the practice list size, which is divided by the national average list size, and then this changes annually, and this is how they work out payments for what they consider to be an average practice in the country. You may notice when you go on to CQRS to have a look at how your QOF is doing, there will be a small section on there that will tell you that you are possibly can work to either a higher amount than the national average or a lower amount, and that is worked out initially on your list size and then looking at the contractor population index. So an average practice for the years 23-24 was 9,639 patients. They haven't told us quite yet for 24-25 what they are using as the average list size, but it will be there or thereabouts potentially, unless there's been an awful lot of changes with merging practices or handing back of contracts. Then on top of this, to look at our QOF prevalence, we do look at an adjusted practice disease factor, known as the APDF, which is your average disease prevalence divided by the national average disease prevalence. So it's getting to be quite a lot of maths here, something you don't actually need to know. It's just, again, some background. If you would like to actually have a look at what the national average is and then drill down to your average prevalence and what would be expected of you, you can look on www.gpcontract.co.uk. You need to slowly break this down. It shows as, rather than an ICB level, it will show you what your old CCG levels are, and then you work through those until you get down to your individual practice. As you get those figures up, that will show you sort of where you should be sitting as a prevalence factor. And then you can see where you are in comparison to that to give you an idea of what areas probably have been a little neglected and can do with a little extra work. There will be a handout that will come out for the national prevalence, and it looks a little like this. So it will give each area of the QOF and the percentage that you are expected to be in if you are in a very average practice of an average size. And don't forget that when we are considering prevalence of QOF, areas in great deprivation are often areas where you will see higher disease prevalence. So it's not just about the size of the practice. We are also having to consider the deprivation. So that could be areas such as diabetes and COPD and heart disease are more prevalent within those areas. You may also find that you have a higher prevalence if you're in an area with a lot of elderly patients, and a much lower prevalence if perhaps you are looking after a university area where there is a lot less disease prevalence in the younger people in our generations. So away from the bits that you don't actually need to know, but maybe it's a bit of understanding for the background, we'll have a look at the QOF, and the bit that you're probably the most interested in is the money, I would assume, being management. Obviously, if you are sharing this video link with your nurse team, perhaps to get them a little bit of chronic disease assistance and help, then that would potentially teach them and show them how to increase prevalence. And I'm sure they'll be looking on that and on a more clinical level than yourself, but the two can merge together and give a better clinical, excellent coverage for your patients, whilst you're also considering bringing in a little more money to the surgery for work that you are already doing, but perhaps not being paid the full amount for. So to work out your QOF work is worked out by your points that are achieved, your pound amount per QOF point. So this year that's £220.62, times the CPI, times the APDF, the areas that we've just talked about, your contractor index times the disease prevalence. So you are looking at not only the size of your practice to look at how much your QOF is worth, but you are looking at how many people in each different disease area, which can then enhance your QOF payments. Your prevalence data will not be extracted until the end of the year on March 31st, so you have all year to work on it. But do be aware that if you are increasing in an area with a backdated date, because it's just an area that has been missed for coding reasons, if there are extra things that are attached to those particular parts of QOF where you have to get people in to maybe get a blood pressure reading or to get them on a certain medication, keep that in mind to make sure that you have enough time to do that. If it's an area where it is simply a disease register that needs to be added to, then that takes away some of that worry, and you can work right up to March 31st before, and then that will be extracted after business on March 31st, and that could increase your QOF amount that comes through for the year. So the guide in your bundle that will be coming out when applied for in the manner that will be given to you when you get this link will show a very approximate amount that can be gained each time that you add someone to your particular disease register list. This is a very approximate amount. You cannot work out the exact amount unless you go through all that list of sums on an individual basis for each of your practices. But the approximate amount which was provided by Ardens this year, and some of you may be lucky enough that you can, your partners have paid for Ardens. This can help you increase your prevalence, and they have given an approximate amount for when you add people to each list. Personally, I use this particular guide in my bundle to place my amount of prevalence, which you can get by going onto your provider, such as EMIS, and having a look at your QOF lists, which will show the exact amount of people within each disease area. And I complete this within the line for the month. So for instance, April would be completed, then May, and I continue throughout the year, and I share this information with the clinicians that are also assisting to work on prevalence. And then we can work out and look at that prevalence is perhaps increasing. We can also consider, are there certain areas that we have to do some work, maybe for a quality contract or a localized contract? And then this could be used to double that. So for instance, in some areas we're working on respiratory and increasing our asthma and COPD list. So if we increase them, that may help our quality contract, whatever that may be, but it also will add to our prevalence, increasing our money in general practice. So there are sometimes a double need to look at why we're looking at certain areas. So that's the theory behind it, and this is how you can work through and show your partners the work that you've been completing in the background and how much money this is worth to them. It also may encourage them to do some of the work themselves as they see that money going up. But now we need to talk about how do we do that. Well, on a day-to-day basis, we can look at summarising our patient records. I know sometimes when things have come in GP to GP, we can have that assumption that this has been done in a previous practice to a high standard. I always get all my records checked, summarising wise, firstly for clinical excellence, but also to consider that there may be some hidden money in there that has been missed. So summarising and having a high quality area of summarising by someone that has QOF in mind can also make a big difference. And then we look at coding. So coding our letters as they come into surgery. If we can also keep QOF in mind as well as clinical excellence, we can also improve our areas of QOF prevalence as we go through, as each letter is coded. But we can also go back and have a look at each area and code after the fact, but this may capture people as we go along. There are also some very quick wins you can do. As I mentioned before, Ardens has some really good searches that you can have a look at, which are there purely to improve your QOF prevalence. Your data quality localized teams should also be producing certain searches to assist you with this, but you can of course make searches in-house on your particular clinical system that can help you work through this. So let's have a look at the particular disease areas that we're going to consider. I've put together asthma and COPD, although they are two different areas. They are both respiratory, obviously, and there are things that we can think about. Some people do crossover as well into both areas, and you may also have some people that you're on your asthma list that perhaps actually their respiratory disease has become worse and they are now really to be considered under COPD, either as well or instead. That will be a clinician that will decide whether it's as well or instead. So there are a few things to have a look at. Now, a few years ago, and I found this in several practices that I've gone in to assist with, there seemed to be a little bit of a thing to resolve asthma and even resolve COPD. towards the end of a QOF year to balance the QOF to make sure people hit their full QOF targets. It wasn't necessarily done correctly. I am suggesting that you have a look back at anyone with a resolve code, particularly if they have a resolve code, but they're still ordering regular inhalers and turning up for their flu vaccine, because you will see the word asthma, assume they are sat on your asthma list and you are being paid for them, whereas actually once their asthma resolved is on there, although you are continuing to do the work, they have perhaps dropped off the list and you are not being paid for those patients as part of your asthma list or even your COPD list. You'll also have a variety of patients who have ordered inhalers across the year and they're not on a register at all. Now, that may be that a doctor has given them an inhaler as a one-off. So you will have to have someone actually clinically have a look through those patients. But if you have got regular inhaler use and they are not on any chronic disease register, we need to understand why that is and maybe get them onto the right register. Also, if you've got patients with a FEV score, have the nurses have a look if they haven't been placed on a register, and perhaps they should have been. It's quite easy when the nurse is very, very busy that they are working through seeing if someone has a diagnosis of asthma, doing all the right thing with pheno, spirometry, and all the hard work that goes into that, and then forgetting the very last bit of coding them as asthma. Even adding them on for asthma reviews and organising all that sort of thing, but not getting that asthma code on there to make sure we're being paid. If you are coding and you are working with EMIS, for instance, you will find that all of the codes that add people onto a QOF register or are considered for QOF will have that little QOF symbol next to them. So you can make sure you use the right code. There are also some people that will have things like history of asthma that will not place them onto the asthma list. It has to be the proper asthma QOF code. Same with COPD. A lot of people are still sat on an emphysema code rather than the newer COPD code. So please take a look through there. Again, you can use Ardens or your data quality searches, or you can build your own searches within EMIS or System 1. Then we can think about CHD. Amazingly enough, there are some people that are sat not on a CHD list, although they've had a coronary artery operation, and you can look for coronary artery operation or a coding for stent, and then check your letters and your where that happened and your results, and make sure that your CHD coding as per QOF is used to make sure that you are being paid for them on that list. You can also look for CHD monitoring. Sometimes people have that initial operation, they are added onto your CHD monitoring, so they are invited in regularly for their checkups, but you are not being paid for them having CHD. So that's again something worth having a look at. One where most people are not up to date with is their CKD lists. Within those CKD lists, you don't get an awful lot of money for adding someone on to your CKD register. But I've had one of my clinicians have a look through several records, and she managed to add on 50 or 60 people with about 40 minutes of work. Okay, you only get around £4 to £5 per person that's added on, but that all adds up when there's quite a high bulkage of people. Often this happens because your QOF is generated on stage 3 to 5 kidney disease. Many people may be showing on stage 2 where they have mildly decreased function, and then as they get older and their CKD gets worse, the actual staging of the stage 3 to 5 is never added on. It's just assumed that you're getting paid because they are down as having CKD. So this is worth a look at. Often as well, a clinician will order blood tests and an EGFR of less than 60 kind of shown up a couple of times in the past year or 18 months, but it's not been coded as CKD. With this, you are going to need a clinician to have a look at it that feels confident and understands CKD. You can also have a list of people whose EGFR has been under 60 in the past year, but repeat bloods haven't been done. You'll need 2 sets of bloods to confirm this. Again, I would have a clinician have a quick look through that list and say, are we okay to get them back in for repeat bloods? But then do remember to go back to them again and make sure that they get coded so they get on that list if they are again under 60. Could also have a look for CKD review or CKD monitoring codes, which will often show up. But it's a really good, quick and easy one for a clinician to fit in at times if they have a little bit of spare admin time to have a look at that. Or perhaps if you've got medical students in who are coming in to do some audits for you, they can do some background work on this to assist you. Now, dementia, you won't add so many to this, and this is a definite, quite a serious clinical look at this, unless it's something in a letter directly with a diagnosis from the memory clinic or similar that hasn't actually been added to your notes. This is worth around 137 to 140 pounds for each person you add in. So you will need to make sure that they are being coded. Often there'll be a letter saying seen in memory clinic, but perhaps the diagnosis has been missed, or dementia monitoring codes, dementia care plan codes, where perhaps the initial diagnosis hasn't gone on. Where you can code directly from a letter as an administrative person because that has been put together by a clinician. But if you have got regular dementia medication showing up on your prescriptions, but perhaps no diagnosis of dementia, I would get the pharmacist to have a look over if you can't see a diagnosis. And if not, maybe dig a bit deeper and find out why that medication is happening if they haven't got a formal diagnosis. So this is all areas to think about, but you may not get so many people to add on there unless there's been a missing in your coding. Then we'll look at diabetes. Unless a patient has been coded incorrectly in the past, or they have gestational diabetes, which is something that could be resolved, diabetes is never resolved. You can live with diabetes without medication and you can bring your bloods back to a normal level. But once you have been coded or considered as diabetic, you will remain as diabetic. So therefore, have a look at those diabetes resolve codes. Again, this was something that I have found has happened in the background in 1 or 2 practices just to hit QOF targets at year end. Not necessarily in your practice. This could have come someone that's come in from another practice. So do make sure that you are looking at diabetes resolve codes and checking to see how that was resolved or if those patients are in fact diabetic. You can have a look for diabetes monitoring or diabetes review codes. Again, for people who are not on your list, but they are regularly having reviews because that just proper QOF code has been missed at some point. I would have to suggest you got a diabetic nurse to review any HbA1c over 48s to see why they haven't been coded as diabetes. I certainly wouldn't be coding anything myself without a clinician looking over it if it's a proper diagnosis that's been missed rather than something that's just been perhaps miscoded. There's also a query diabetes code that does show up sometimes. This can be when a nurse is checking someone for diabetes. They have lots of symptoms. They're going through the blood testing. They put queries diabetes on, and then when the diabetes has actually been confirmed, they have forgotten to add on the actual diabetes code, which is the code that you get paid for. So again, that's worth having a look at those query diabetes code. Believe it or not, there is the odd surgery that has patients who are on regular insulin, but they're not on the diabetes list. So that's another one to check. Not so many of those, but there is the odd one. Then we'll move on to epilepsy. So again, we can have a look for epilepsy resolved but these patients are still on medication for epilepsy, or anyone who is ordering epilepsy medication, regular courses of anti-epileptics, who is not sitting on your epilepsy register, please get a clinician to oversee that. That's not really a decision to be made by anyone in admin, but it is worth a little look. There was a time where epilepsy had various things that you had to complete under QOF. Now it is just a list only. So sometimes Resolve may have come back from those times, but may need a relook at. Now I'm going to talk to you about the biggest money area one, which is heart failure. You will find that if you get a company to come in and they only have a limited time to have a look at your QOF, generally the areas that they will look at is your heart failure and your osteoporosis, because they are your big hitters. With quite easy money to be found, because things often get missed in both areas. And these are generally coding things rather than clinical decisions to be made. It does involve going back through some very intricate letters to ensure that you've been coded for absolutely everything. So first of all, have a think that heart failure is actually under two different registers. You have got regular heart failure and you have got heart failure with LVSD. You are paid an awful lot more for those patients with heart failure with LVSD, up to £115 if you add someone into that part of the register. So it is definitely worth spending a little bit of time. You will have patients that are just on your heart failure register, where you get around £56 to £60 to add someone into the heart failure register. They may be sat in there, but they are not on the heart failure with LVSD, and actually they should be. And sometimes this is a really straightforward coding. So firstly, check through your heart failure nurse letters to check that everything has been coded. Look for any LVSD assessment codes. These are often shown up as part of the echo. So if you open up the echo, and you can see various bits that are written in there, and it will tell you if the LVSD is normal or left side normal or not normal, and therefore it's worth coding that part. This is something that your general read coders may have put, that an echo has been performed, but they won't have looked deeply into that coding because they won't be aware of the money side of things. So have a look. And then we do have those patients that are coded as LVSD, but the actual heart failure code hasn't been put on. So it does need both codes. So have a look for that and make sure that you've actually got both those codes on. And it is really quite clear in the letters when you have a look through. Again, there's some really good Arden searches and some data quality searches that will pick up various people that they will notice that haven't got LVSD, are in your heart failure list, and perhaps could do with a look at. It doesn't mean you can code all those people. It means you need to go in and actually spend a little bit of time looking and making sure that you're getting paid as much money as you can do for all of those areas. Next, we'll have a think about hypertension. You will have patients who are on antihypertensives but are not coded for hypertension. That's definitely something to have a look at, and a discussion with a clinician as to why that may be. If you've got patients with 2 or more high readings, check with a clinician if we need to be looking for adding them to the hypertension list, or whether they are happy that those high readings were there for another clinical reason. Perhaps they were in a period of ill health and now they've come out of that. Sometimes you'll see, again, for hitting QOF targets, that people were happily going through as administrators and resolving hypertension for people who are still on hypertension medication. Those should never have been resolved. If those people are still on their medication, they're on that medication for a reason, and the medication is not resolving the hypertension. It's not making them better, it's making them manage it. So therefore, those people should be coded and on your hypertension register. It does make things more complicated. Do not do this right at the end and then throw your QOF targets at the end, because you'll have to get all those people in for a blood pressure reading. But it's worth also having a look if you have left it till February or March. Some of them may have had a reading throughout the year that would hit in your targets and get them on. If not, maybe wait till April if you've left it a little late. Now, mental health is a really tricky one to decide what to do. There are people, again, who are using mental health resolved codes. Their mental health may have been resolved. That's a clinical decision, not an administrative decision. If it is been used for exception coding previously, it maybe shouldn't have been resolved, and that's something to check with someone clinical. Mental health isn't for all of your mental health patients. They have got to have severe mental health to start hitting into that QOF list. So various codes have been used in the past that haven't added people on when perhaps they should have been. That's codes like history of schizophrenia. Actual schizophrenia will put them onto the mental health list, but history of won't. So that's one worth looking at. And also have a look for patients who are on antipsychotic medication or on lithium that do not have dementia, and that is something worth having a chat with a clinician to see if they should be coded to be on your mental health list. It is amazing. There are an awful lot of people with quite severe mental health that have been missed due to things like these history of codes. So it is worth spending a bit of time. It's worth about £88 to £90 if you add someone onto your mental health list, but there won't be big numbers of these. It will be quicker and easier maybe to get your heart failure ones rather than your mental health ones. So you need to consider where you're going to put your time in. Then we can have a look at depression. Now, depression, we went through a phase where clinicians were a little bit concerned adding people onto the depression register because they had to get patients back within the 10 to 56 days afterwards to have a review. So people happily resolved depression if they didn't get them back within 10 to 56 days and they weren't on medication. That's maybe a clinical decision to make, certainly not an administrative decision to make. So do have a look down to see if there are any depression resolve codes that perhaps were done for QOF reasons that shouldn't have been, and then have a look at whether that actually was resolved. You can also have a look for patients who are on repeat antidepressants, but they're not coded as having depression. Because they will sit there on your depression list. And now we don't have to do the 10 to 56 days getting them back in. It's good to do it for clinical excellence, but if they refuse to come in, you are not going to fail your QOF at year end, so you need to make sure they're on that depression list. Also talk to your clinicians. Some of them use non-QOF codes quite regularly to add people sort of with low mood. There are old codes that simply say depression, but they don't have that little QOF box next to them. These are all ones to go back, have a look at and see if it really was depression and whether they needed to be coded. And if they did, they need to be coded at the time that happened, not now. So that needs to go with a back code when it actually happened to them at that point. So do have a look back and see if there's anyone you can add on for that. Now we're going to move on to obesity. This isn't worth a huge amount of money. We're only looking at about £3 or £4 every time you add someone onto the register. But there is the secondary weight management enhanced service that may kick in or will kick in if someone's added to your obesity register. So there is, again, if we're looking at it from a financial point of view, there is another avenue to make some money there. And also then they are entitled to a flu vaccine. So if they are under 65 and they don't hit any other chronic disease, but they are obese, they are entitled to a flu vaccine under that, but not if they've managed to drop off your list. Now, if they've dropped off your list because they've done their weight management and lost lots of weight, that's fantastic, because clinically, obviously, that's what you want to see. But you will find that there is a very, very simple thing that any of your admin staff can do. It's something I do monthly and have a little check of. And that's patients who have had a weight added. It might be by a clinician, or it may be from a hospital letter, but they haven't had their BMI added. Generally, an adult's height will be on there somewhere. Just a quick click of a button means their BMI will be calculated from their new weight that's been added. And then if their BMI suggests they should go onto that obesity list, they will be automatically added because their BMI is at that height. But if their weight has gone on and their BMI not gone on this year, they will start to fall off the list, and that list can go down dramatically. And obviously you do need them on that list to call them in for weight management. And therefore, so there is a double reason to do this work, even though it's not a huge amount of money per person that's added on the list. The knock-on effect with the flu vaccines and the weight management makes it a worthwhile piece of work to do. The other big hitter that most people go for is osteoporosis. It's worth about £33, £35, which isn't as high as some of the others, but you will find multiple people that have not been coded for it on your list unless you've got exceptional coders. There are two different osteoporosis lists, and you need 2 or 3 codes, depending on the age of the patient, not just one code to be added. If any one of those codes is not added at the time, so in the correct date, then they will not be added to the list and you are losing money. I had an administrator in a previous practice that spent an afternoon on our osteoporosis list, just working through adding the extra codes where they'd been missed, and made us about £4,000 in an afternoon. Obviously, that money again stays within the practice on that osteoporosis list until those patients are no longer on your patient list for any reason. So therefore, it's really worthwhile getting them on that list. So to make it really straightforward, anyone who is over 75, who has a fragility fracture, you will probably find they've been coded with the definite placement of a fracture, which is the coding that you will need for all clinical reasons. So if they've fractured their pelvis or fractured a part of their body, that will be added on as that particular fracture. They also need the code that just says fragility fracture. Not anything to do with any part of the body, just fragility fracture. That code needs to be on as well as the code of the exact placement of the fracture. And then as well as that, so we're going for our next code that needs to be on, is the code saying osteoporosis that has the little QOF sign next to it. So if you've got a fractured pelvis, fractured femur, any part of the body, you also need fragility fracture plus osteoporosis code. And if they sit there together and the patient is over 75 at the time of the fracture, not over 75 now when you're looking back, but over 75 at the time, that will trigger and automatically add them to your osteoporosis list. If they were anywhere between 50 to 74 when this fracture happened, so not the age they are now, looking at the date when the actual fracture happened. If they were under 75, they will also need a DEXA scan, and that needs to be coded as DEXA scan. So as long as you've got that scan on, plus the osteoporosis code, plus the fragility fracture code, it will automatically add them onto the osteoporosis list. If you've missed any one of those codes, like it just says osteoporosis, but you haven't actually coded the word fragility fracture, they will not add on to that list. You will not be being paid. So have a good look through those lists. Your local data quality searches should have something on there. If you use Ardens, it will actually throw everything into an Excel for you, which will show you which particular codes are missing and the dates that those things happen, which will give you the opportunity to go back and just add in any code you can, and then get that having a look at those to see if you've managed to add some people onto your osteoporosis register. And then there's rheumatoid arthritis. So if this one's a little more complicated, you can check all patients who are on a DMARD without having Sjogren's disease, psoriasis, IBS, etc. I would get a clinician looking at that. We're not clinical generally, and it's not something that we should be deciding to add someone to a list. You can look at query RA, find when that was, and then go back to see if they've been seen within a hospital clinic where a diagnosis has been missed to add on, or RA monitoring, RA plan and RA review, but are not actually set on your rheumatoid arthritis list. So these are all areas worth considering within your QOF. So we've come to the end of the part where we're discussing how to add people onto the QOF list. And hopefully that's been useful for you. Some of you will be experienced managers who will know all this, and I hope it's at least encouraged you to maybe go back and have another look at things. You need to do this regularly. You only need to have a different coder in, or patients coming in from different practices where they haven't been looking at QOF prevalence, and you will find some missing money. And even if you've got great coders, they're all entitled to an off day and they may have missed something. So it is always worth having a look back and maybe having regular meetings with your coders to discuss with them the importance of QOF prevalence and how this adds to the surgery money. I'm very happy for you to use my slides to teach your nursing team or to teach your coding team how to increase QOF prevalence and why it's important. There are ways of checking how we've done, and we can do this for, obviously it makes us feel good, but it is also worthwhile to show our partners within meetings and to share with our teams that the piece of work that they've spent doing and maybe not really understanding why they've done it, why that has made a real financial difference to the practice, and show them how that happens. If you do that and you can show that we have increased prevalence, that will give you that extra feeling of an extra boost. And those of you that have ever joined my courses that I have run on making a business plan for your surgery, any work you do on this with your reports that show the work that you've increased would sit very nicely in your business plan to show how you are improving work as we go forward and how you're improving the finances of the practice as well as the clinical excellence. Also quite a nice thing to show CQC that you are keeping on top of your coding. Not the money side, but to show that you are interested and working on the clinical coding to improve the clinical QOF prevalence. So when we're in CQRS, you will know that you could go into your achievement summary and you can look here at your achieved sum of QOF and how much money you can make. And there is an area on that where you can look at the maximum amount of money that you can make. And that is worked out and determined by your QOF prevalence, because the more your prevalence increases, the more amount you can actually make across the practice, as well as extra patients joining. So one thing I like to do is do some swapping of dates when I have done a big piece of work. So for instance, if I have done a big piece of work in August on increasing prevalence, I will go back and you can actually change dates. There is a drop down within your QOF CQRS reporting, and you can pull up a date maybe in July that will look at the maximum amount of money that you could achieve within QOF if you hit all of your targets, and then rerun that in September because you've done the work in August. Rerun it in September and you will see that amount will go up if you have done some work. So if perhaps you think by looking at the table that I have produced for you, that you have made, you've added maybe 50 people to a CKD list and 20 people to your osteoporosis list. You've moved some heart failures into your LVSD. You can work out roughly by the different amounts, roughly how much money you think you will have added in. And then you will have a little bit of proof here by changing your dates where you can have a look at everything and work out exactly what you have made and share that really good news with your partners to show that at a difficult time, you are improving the financial state of the practice. Within this, as well as the video that obviously you're watching. If you do apply for any documents, I have done a what to do list. So it will have each disease area and what you do within that disease area. So you don't have to keep going back to the video. You will have a list of each area and how to improve your QOF prevalence in those. So I'm hoping that has been helpful for you all. I do thank you for your time that you've taken to spend watching this video, and I hope it's been useful. Really hope you get some good results on your QOF prevalence and you enjoy adding to that and showing the difference that you're making in general practice at quite a challenging time. Thank you so much for your time today, and I'll see you on the next video or training session. Thank you and goodbye.